Good morning, everyone. Thank you for joining us for today's training, Preventing Clinician Suicide, Overcoming Barriers, and Reducing Stigma to Care for the Healers. My name is Rick Brown, and I'm the Associate Director of Communications and Membership with the Association of Clinicians for the Underserved. I'll be your host for today's webinar, which we're honored to be able to co-host with the American Association of Teaching Health Centers. If you have any technical issues during the webinar, please reach out to my colleague Joshua Chung via the chat. For those of you who are new to ACU, I just wanted to give a very brief introduction. We are a transdisciplinary membership organization uniting clinicians, advocates, and organizations in the shared mission to establish a robust and diverse workforce to help transform communities to achieve health equity for all. We do that by providing advocacy, professional education, training and technical assistance, and more to develop and support clinicians in the healthcare workforce caring for America's underserved communities. We invite you to learn more about us and membership with ACU at clinicians.org. Also, if you're interested in more resources on suicide prevention, whether that is for patients or clinicians themselves, we also encourage you to visit our Suicide Safer Care page. You can find a variety of resources there, including fact sheets, toolkits, archived webinars, and our new social media toolkit for raising awareness of National Physician Suicide Awareness Day, which of course is approaching on September 17th. I'll ask Josh if he can, he's already put the link into the chat, and you can also scan the QR code as well. Also, before we begin, I just want to go over a few quick housekeeping items. First, we will be recording this session, and we'll send you the recording and the slides within a week of the webinar. We also encourage you to ask questions via the chat during the presentation as you think of them, and we'll also have a dedicated Q&A at the end of the session. So if we're not able to answer on the fly, we'll definitely get to your questions then. At the end of the session also, please be sure to complete our evaluation. It's very useful to help us and continue to improve the quality of our trainings. Lastly, I'm honored to introduce today's speakers. Dr. Verna Little is the co-founder and special advisor for advocacy and research at Concert Health. She is also the Chief Operations Officer and co-founder at Zero Overdose, as well as a member of ACU's Advisory Council. She is also a national expert in suicide prevention, a faculty member for Zero Suicide, and previously served for over 2 decades as a senior vice president for a large FQHC network in New York. We're also pleased to have with us Dr. Eileen Barrett. She is a rural internal medicine hospitalist, former National Health Service Corps scholar, and a faculty member with the Institute for Healthcare Improvement. Board certified in internal medicine, she received her MPH from the University of North Carolina at Chapel Hill and her MD at Georgetown University. She also completed her internal medicine residency at Oregon Health Sciences University Hospital and completed a rural faculty development fellowship through the University of Arizona in 2009 and a medical justice and advocacy fellowship through the Morehouse School of Medicine and the American Medical Association in 2022. We're excited to have them both presenting with us today. And with that, I will turn it over to Dr. Little to kick us off.
Sure. Thank you so much. Really glad to be here. One of the skills that I've actually honed over the past couple of years was the ability to multitask on meetings. So if people have any questions or comments, we can, sort of watch that as we're going along as well. So please feel free to put in comments or thoughts, and we can stop and talk about them, or I can kind of weave them in as we're going along. So a couple of things we know is that many of us in the healthcare business, in the caring business, we oftentimes will sacrifice our own well-being. I think we see this pretty frequently. And I thought it would be helpful. I, have the privilege of going around and working with different organizations around the country. And I was in a hospital, fairly rural hospital in Montana, doing some suicide safer care work. And the woman who was there with me was talking about how, she really had not been taking some time and was working and had gotten a large grant and was really, had been focusing on work and actually canceled a trip as a result. And then we started to talk a little bit more, and she shared how the organization had lost 2 staff members to suicide in the last just over 2 years. One of them was a longer term employee and the other one not as much, and the impact that it had on the team and the organization. So I think it's really important, and we're going to spend a lot of time talking and calling some attention to really what we can do to help keep everyone safe and care for ourselves. Oftentimes what we know is that people really feel as if there are barriers. And I know going around the country as part of this project with ACU and talking to medical students and residents, that they oftentimes felt like they couldn't do anything. They didn't have the time, or that if they actually said, hey, I need help, or I need to take time to go talk to someone, then that wasn't going to be something that was going to be accepted, or people would think they weren't as qualified or weren't as strong or weren't as capable. Go ahead. So one of the things we know is that we lose a physician to suicide at least every day. We know that oftentimes we have physicians in particular that won't seek treatment or don't seek treatment for lots of different reasons. And I think one of the things that we need to do, starting with medical students and residency, is that we actually talk about suicide and we talk about what benefits there are and what support there is for mental health treatment. And one of the projects that we've been working on with ACU is Suicide Safer Care. And we've trained now over 3,500 primary care providers in their teams in about 32 states. And many of those were residency programs. And not one single time in any residency program that we went to, every single time a resident came up to me and told me about a resident or a medical student that they had lost to suicide. And so it was really striking to me that that happened every single time, and how important it was. And I know, working with a family practice medical residency program in New York, I one time actually did a survey during rounds and was really surprised how many of our own residents at the time said, yeah, I think about suicide now. I've thought about suicide in the past. And I shared it with the director because I thought this is something that we really need to do something about. We need to be leaders in the field and start openly talking about suicide, because I worry it's not an if, it's a when. Go ahead. And so when we think about suicide in healthcare workers in general, I think one of the things we've learned is that we didn't actually look at it really closely until the past couple of years. So oftentimes it's the difficult work hours, right? It's rotating shifts. It's oftentimes, especially now with staffing shortages, not getting a set sleep schedule or not having enough time, not being able to schedule. I talked to a nurse recently and she said, I do get some time off, but I can't schedule anything because I never know when that's going to be. And so even though I get the time off, I can't schedule the things that I know would be really helpful for me. Also very difficult situations with patients and families, right? That it can take a toll. Thinking about all that we went through with COVID and what that looks like. And I think we are only beginning to understand the impact that COVID had on our workforce. Thinking about just the daily exposure. I know that I've personally spent a lot of time working in emergency rooms. And part of you says, well, you know, I've seen everything and I'm pretty tough, but there's always a part of you that just gets kind of exhausted from having to be tough all the time. And I know I can say that from my own personal experience. And also just access to lethal means, to medication. And also, you know, I had a nurse one time that I worked with in an emergency room, and she shared with me that she was thinking about dying by suicide. And what particularly struck me about that conversation was, because we worked in the emergency room together, she had seen all the different ways that people had tried to or had died by suicide, and was actually really weighing, well, people who try this, they almost always live. People who try this almost, and it just struck me that she had really incorporated all of that information and was really trying to think and manage her own suicidal thoughts. And so that's something that, you know, I found very interesting and that I think is more common than we might let on. Go ahead. So also when we think about suicide, we think about burnout. I was recently at a family practice leadership meeting in Texas, and they were talking about burnout. And the number of people, they had about 3 or 4 questions that they asked people to really gauge burnout. And it was interesting to me that people didn't report as much burnout during COVID, but since COVID, it has dramatically increased. And they talked about more so in women than in men. It was pretty striking, but the numbers and the prevalence of burnout was pretty high. And so really thinking about what that looks like. And now how do we address burnout? First of all, how do we recognize it? I really like the fact that they had about 3 questions that they asked, because I thought that's really gonna, be better able to elicit some response. But I think we really do need to pay attention. And I think people throw out, oh, burnout is sort of like a generic term. And we forget the fact that it really does have some criteria, and that we really do need to pay attention. It does exist, and it has a dramatic impact on people's performance and their well-being as a whole. Go ahead. So when we think about the numbers, we think about suicide among physicians, and the number is really way higher than the general population. When we think about losing a physician almost every day to suicide, and actually the number has gone up a little bit, I understand recently. We also know access to medication. So it's interesting that different professions choose different means, and people in healthcare oftentimes will choose medications. And I think some is access, and also some is knowing actually what a lethal dose might be. Go ahead. Also, I think many people might be self-medicating. And so that actually, when we think about perhaps unintentional overdoses and deaths, I might put them in there as well. So when we think about female physicians and the suicide rate being higher than the general population, and also having a higher mortality rate, we actually didn't really look at the suicide rates in nurses. I'm not quite sure why, until a pretty large study a couple of years ago. And when they were 33% more likely to die by suicide, to me, that was shocking. And I actually wouldn't have expected it to be that high, but to me, that is something so actionable for all of us in healthcare to be able to think about what we're doing. And thinking about what the numbers are, particularly for women. And so what does that look like? And what do we need to be able to do? And what percentage of suicides? I mean, when you look at the percentage of suicides, 1 in probably 10 to 12 is a healthcare individual. That's pretty high and pretty shocking. Go ahead. So looking at medical students and residents and just the prevalence of depression, I think one of the things that's so important to do is to actually talk to people coming into a residency program, talk to them about depression and anxiety, because we know anxiety is a huge risk factor for suicide as well as depression. And I think that's a pretty big misconception, is that oftentimes we're looking for the person who is really depressed or has a major depression. But one of the things we know is that we're seeing a lot more anxiety. Anxiety is way more prevalent now. I've seen that shift in the last couple of years. And so anxiety is actually a huge risk factor for suicide. And, one of the things now the U.S. Preventative Task Force is saying, we have to screen for anxiety as well. But I think I bring it up because we often don't think of that person that's very anxious as someone who could be at risk for suicide. And so really important to sort of think about it as well. And that 1 in 5 of our medical residents meet the criteria for depression, and 3/4 of them for burnout, I think tells us why they're so much more at risk for suicide. And really thinking about why they're not getting treatment. Some of it is the scheduling, right? That rotating schedule. Some of it is really concerned that they're not going to have the time, or that they're going to be seen as incapable, or if I can't care for myself, how can people think I could care for patients, is what a resident told me one time. And I was always struck by a pediatric resident in New York City. And we did this training, and he stayed afterwards, and he sat down and he said, I just want to tell you my story. And he said, I was a resident and I tried to die by suicide, and it wasn't a successful attempt. But I never told anyone in my residency program. I never told my director, and I felt so alone. And I felt like I would be standing there, and I feel like I didn't know what to do, and I just felt lost. And so when I watched him and he sat there and his body language as he told that story, it just really resonated for me at how many residents we have and how many trainees, nursing trainees, residents, behavioral health trainees that we have who feel the same way and just feel like there is no way to be able to reach out. Go ahead. So we know, and that's why people don't reach out, right? So even though we know that they're at higher risk, they are way less likely to reach out. And I think when we think about changing a culture, this is something that has to come from the bottom up and the top down. We have to be able to have the discussions. We have to say, you know what, not only is it okay to ask for help or to go seek help, but we actually encourage you to do so. And I think that is a dramatic shift in culture, even if it means that we're short-staffed and somebody might need to take some time off. And I think it's hard, and I think we need to really train our managers and our leadership how to have those discussions to say, like, you know, thank you for being so dedicated, but your wellness really needs to be able to come first. Go ahead. So we also want to make sure that we're sharing information. So one of the things that this person that I talked to recently talked about was the organizational response. And so she said the organization was just reeling from having lost someone to suicide. And I think it's so important to think about postvention beforehand. You know, all of us organizationally have to do these things, those hazardous vulnerability assessments, right? And so it's important to really craft the email from leadership beforehand, because oftentimes what I've seen happen a lot is something will get sent out and there is no mention of suicide. And it's important to be able to acknowledge and to be able to use the word suicide and to acknowledge. Or it's oftentimes what happens is someone said, well, they died by suicide. We don't want people to know, so we're not going to send a message. And that's not the right message that you want to communicate to the organization as well. And so really thinking about what the message is, and then also thinking about it beforehand so that you're not crafting it at a time when you're reeling from having lost someone to suicide. Go ahead. And I'm going to turn it over.
Yeah, thank you so much, Dr. Little. There was so much that was in there, and I'm so grateful that you covered this so broadly. And I am so grateful that you have been doing this work for so long. And thank you for sharing those stories. Our stories really matter, of course. I think that everybody who's joining us today, that they also have a story. What people who are able to look at the slides, what you're seeing is a QR code and an image. The QR code is to a blog post that I wrote for the Institute for Healthcare Improvement. The image is the one that they selected, and it was the idea of we need to stop having these barriers to clinicians receiving mental health care. And if I may also reflect that what I wrote about there was how once I was at a conference and the presenter had asked how many people in the room had, in this case, it was mostly physicians, although I believe that it would have been similar if it was physical therapists, social workers, medical assistants, CRNAs, CNAs, really every member of our wonderful interprofessional team. But the presenter asked how many people know a physician who has died from suicide, because it was mostly a physician audience, and a lot of people raised their hands. And then he said, keep your hands raised if you have known 2 physicians who have died from suicide. And still, although it was fewer, still a lot of people had their hand raised. And then he asked about 3. I kept my hand raised the entire time. I know that when we were preparing for this call, I had mentioned that I have known 4 physicians who have died from suicide. And then, of course, I remembered that I knew a 5th. And that has been when I was a medical student, one of our faculty members, when I was a resident doing my specialty training, a co-resident, I walked into traffic. as an attending in a rural area, one of my a colleague died from suicide, also two died by suicide. And then a very close colleague, someone who I had worked with very closely, who I had said to him, we were sitting across from each other in a meeting on a Friday afternoon, and I will remember this until I die. And I said, something seems off. Are you okay? And he said, I'm fine. And I said, really, are you feeling okay? And he said, I'm fine. And I said, okay, you know. He said, oh, I just had a cough. He was kind of dismissive of it. We continued through the meeting, and I believed him. And that the next morning, or excuse me, that night he was on call, he provided outstanding care. He was a pillar of the community. He was one of the most respected physicians. And then after he finished his call, and after he signed out the patients that next day, then he killed himself. And that was, of course, devastating to everybody involved, an entire community. And then also, when I was working in academia, one of my residents also killed himself. And so our stories matter when we talk about this. And I don't say this to make this about me at all. I say this just to say that everybody you know has this story, something like this, and that we should talk about it, because when we can, although we can talk about the scientific literature, and you'll see that I'm going to talk about that, I think that when we can pair that with a story of a person and also an action that we can take, that is when we can really see the change that needs to happen. So with that, I'll ask if we can go to the next slide, please. And just to highlight again, because you heard from Dr. Little, there are a lot of barriers, and the literature really supports this. I'm published in on this area in the Journal of the American Medical Association, Modern Healthcare, the Annals of Internal Medicine, the Brown Journal of Hospital Medicine, a series of different places. And really everything that you just heard, of course, that all matters, and that's all important, and that there are many reasons why every member of the healthcare team doesn't seek care. And you already heard about reputational repercussions and that concern that people will think that you're not quite as good. Or sometimes, we'll get to some of those other ones. Also, those worries about confidentiality, that people, when you're seeking care, if you are in an underserved area, I practice in a rural area. Where I used to practice, one of our clinics, my clinics was literally a double wide trailer at the end of a dirt road. One time when I was going to clinic, there was a cow in the middle of the dirt road, and I thought, how am I going to navigate this? Because I got to get to clinic, right? So if you receive care, it's often from one of your peers, right? Or you're making the appointment through one of your peers. So that can be a concern if you're worried that people will talk about you, or if you're going to be using your insurance, will HR know, things like that. Then also the time pressure, which is, how do you even have time to set up the appointment? How do you even have time to go to the appointment, right? How do you have time to take care of yourself? And then there's a stigma around having the mental health conditions. We heard about that. That I put a little on the slide. You'll see that that's got the bullseye, is because that is pervasive for healthcare workers, but it also is pervasive in our culture. And then a unique one that can come up for healthcare workers are these credentialing and licensing application questions. And people may know that your licensing application, that license comes through your state, and that you cannot practice without that, even if you have the degree. And that your credentialing, it allows you to practice for in an employed situation. So if you put out your shingle and you say, I'm going to be a social worker on my own, well, then maybe you don't have a credentialing application for your employer because you employ yourself. But most healthcare workers most healthcare professionals are employed by somebody else. So we have to do something called credentialing that allows us to have that job. It's essentially your background check. And they often ask these questions about mental health. So I'm going to talk a little bit more about that and ask us to go to the next slide, please. So when people have these fears, they're not wrong, of course, because and these fears are widespread, and that means it's founded in something, right? This is a quote of a title from an article that was in a peer-reviewed journal called General Hospital Psychiatry, and in this said it was a study of women physicians, although I believe that this applies not just to women and also not just to physicians. And one of the quotes in this study of how people who were known to have depression and what were some barriers. But one of the quotes was, I would never want to have a mental health diagnosis on my record. And in this case, that only about 10% of people would actually admit that they had mental health care in any sort of a forum, to any sort of document, to any sort of application, because of all of the stigma, the reputational concerns. So I'll ask that we can go to the next slide. And again, these are widespread and they're not wrong. So this was a journal article that was in the Journal of the American Academy of Psychiatry and Law. And what they looked at was they looked across the country at medical licensure applications. This absolutely needs to happen in nursing applications, social work, polysomnography technicians, pharmacy technicians. This should be done everywhere. But what they did was that they looked for medical license applications, and they looked to see, well, how often were people asking questions about mental health? And also, because this is a journal that is also about the law, then, well, what are the implications of the Americans with Disabilities Act? And in this study that they found that it was widespread, that our licensing applications were actually not in compliance with the Americans with Disabilities Act, because they were asking about conflating someone having a mental health diagnosis or receiving mental health care with their ability to do their job. And so that's the real challenge that is here, and something that all of us can intervene on, that I'm going to ask us, while we take away so much information from this, that we really think, what is one tangible tactical thing that we can do? And specifically related to our licensure and credentialing applications, it is because there is good evidence to show, and I'll ask you to go to the next slide, please, that when people, it's not just those people who I talked with, it's not just the people that Dr. Little spoke with, that in this case, a national representative sample of an article that was published in the Proceedings of the Mayo Clinic, that they asked, it was thousands of physicians about if they would seek mental health care. They then corresponded those results to if those states had asked about mental health. And then they had some perhaps not unsurprising findings based on what you heard from Dr. Little. And I'll ask if we can go to the next slide, please. And really, this is a multiple page article, but that it boiled down to the what's in the green quote, which is that physicians who worked in states in which questions on medical license applications asked only about current impairment from a mental health condition or included no question about mental health, in those cases that people were less likely to say that they were reluctant to seek mental health care. And so that's really important, because the converse is true, which is that if they asked about mental health and mental health care, then people would be less likely to seek mental health care. And then the next part is what's our call to action, that these findings support continued efforts to develop regulations and policies that encourage physicians to seek help as suggested by others. And of course, if I had written this, I would have said physicians and other healthcare workers, but I understand that the authors focused in this case more narrowly because it was a physician-centered audience. So we'll go to the next slide, and this is the last two slides before we transition back to Dr. Little, and that is that I think that when we're doing this conversation, it is a natural question for people to ask, well, but I really want to make sure, though, that the clinician who is taking care of my mother, or the clinician who I am employing, or the clinician who is taking care of my colleague, that they are not going to provide inferior care. So in this particular article, although again, it was associated with, this is a physician-oriented article, but I think that we have no reason not to think that this applies more broadly. But what they asked in this article in the Journal of the American Medical Association Network Open, what they looked to see, well, does having a mental health diagnosis actually affect the quality of care? And you'll see that this article was titled Association of Physician Burnout with Suicidal Ideation and Medical Errors. And if you point your smartphone toward that QR code, it will pull up this article, because I think it's going to be a handy one for you to have moving forward. But so what did they find in this study, where what they did was that they asked physicians and they looked at the quality of their care, and they looked to see, did they have burnout and did they have depression, and how about suicidal ideation? And we'll go to the next slide, please. And I'll say that this was, again, it was thousands of physicians. They were at all stages of their career. So they were early career. They also were late in their career. They were in inpatient, outpatient. They were subspecialists. Really, they were very diverse. They were of all genders, of all races, and all ethnicities. And what they found was a lot of information, but I'm going to distill it down to what you can see highlighted in yellow, which is the results of this study showed an opposite pattern of associations with self-reported medical errors. Burnout, but not depression, was associated with reported medical errors in this case. And so what I want people to keep in mind is that, again, the depression was not tied to the medical errors. The mental health diagnosis was not what was determining what was the quality of people's care. It was actually whether they were burned out. So that's why it's also so important that we address burnout for all the reasons that you heard from Dr. Little. So it really, I think all of this information, I hope that it creates to you, there's a real burning platform in this sense that we really need an organizational approach so that we can facilitate people getting the mental health care they deserve, and that we can prevent suicide and also take care of, address the occupational phenomenon that is burnout. So I will stop there and transition to the next slide, which is when Dr. Little is presenting.
So before we transition, I just had a question, Dr. Barrett. I was sitting here and reflecting for a moment of serving on a professional appointment committee, that in an organization that reviews these applications. And oftentimes when somebody checked yes to a box that they had a history or had been in treatment, I would reflect on those. I was reflecting on those conversations, but also about people's concern to even bring those candidates for appointment. So in other words, I just don't want to have the discussion, or I just don't want to have to deal with the committee. And so I'm just wondering, and that's my own sort of real life experience, wondering what advice you would give both to people who wanted to put forth those candidates, or even guidelines that you might recommend for committees. Like, I know I'm kind of putting you on the spot here, but wondering what your thoughts are.
Yeah. So I will have a little bit more about that later on, but I think that maybe I heard you first say the guidelines to the committee. The first is the best practice is to never ask about mental health. We may be violating the Americans with Disabilities Act. So that's like the liability concern, right? We also do know that we are deterring people from seeking care, and we are deterring people from seeking care when the needing care and accessing care are not predictors of the quality of care they're going to provide. So what we should be doing is not even asking these questions. That is a widely acknowledged best practice. If one is having challenges getting their organization to stop asking these questions, then I would recommend referring to that article that we just referred to. I'm also going to later on show some resources that are publicly available, including a QR code that people will be able to refer to help one make their case. And so I might ask if we can get into a little bit more detail about that later. And also, if I may say, because you pointed out that sometimes people say, oh, I don't even want to deal with the fact that the person has a mental health diagnosis, so maybe I won't even hire them, is to really then to challenge each other to say, why do you say that? Because oftentimes someone will reflect that they have a bias that actually isn't founded in fact. So maybe they can come up with one instance where one person maybe had schizophrenia, right? And that is very different because that person is impaired. But if they're not impaired and they just have a diagnosis that is treated, such as depression and anxiety, will affect at least 1 in 5 Americans, and they are both treatable. So we really want to get into what are they really getting at, and to just do really deliberate work here. So I see you nodding and smiling. I'll stop talking because I want to hear what you have to say. Thank you.
Yeah, I love that. And what I love is that I'm hoping people will be empowered to go back to committees after this discussion today and say, I'd really like to bring something up, and here's some literature that I'd like to talk about and review as a committee. So I love that we're giving people the foundation, because one of the things that we really want to do is talk about an organizational approach to really keep people safe from suicide, and really identify people that might be at risk. And it really does take an organizational approach. It takes talking about suicide in training and onboarding. It takes having resources posted, and really thinking about a systemic approach, because at this point, it's really not about an if, it's a matter of when. And so being prepared. Go ahead. Oh, we can go to the next slide. One of the things that we often talk about in the Zero Suicide Academy is, where are people and our team members sort of falling through the cracks, and where can we really think about taking better care of people in general? And so, as an example, in caring for patients, one of the ways that people often fall through the cracks is our front desk. If somebody calls and cancels an appointment, we don't have a way to know that they're at risk. Right? When we think about employees, one of the experiences that I had is when someone didn't call or come in for work, they were a no call, no show. And after 3 days, we would consider that they abandoned their job, and we would send them a letter. And one of the things we learned is that one of our individuals actually died by suicide. And so we changed our policy to say, if you don't come in and you don't show, then what we first want to do is make sure you're okay. and that we talked about that change in policy and process across the organization, but even in onboarding to say, we really want to talk about who can we call if we don't hear from you, like getting an emergency contact person and talking about how we would operationalize it and letting people know that that was our approach. Go ahead. And so that's an example of what you might change. And a lot of those processes or thoughts changes organizationally are actually on the Zero Suicide website and there and available for organizations to pull from. Go ahead. So when we think about organizational responses, we really want to start to train particularly managers. I mentioned before this hazardous vulnerability assessments, and we used to sit around a table and we used to have to fill out all the lines. And so we would say, what would happen? We were in New York City. What would happen if a subway went off the L and went into one of our health centers? Like, it was things that like would not going to happen, but we knew we had to have so many scenarios. And then it occurred to us one day that we should actually say, well, what happens if we lost someone to suicide? And we included staff suicide in our hazardous vulnerability assessment. And it really helped us think about postvention, right? And so what are we going to do? What correspondence are we going to put out? How are we going to be able to communicate with people? How are we going to identify those that might be more at risk, right? Because oftentimes our employees, our residents, our trainees, we don't actually know who might be at risk, but we know if we lose someone to suicide, everyone automatically becomes more at risk. That we really want to train. A lot of times our employee assistance programs or our support, are they actually trained in suicide safer care? Do they know what to do if someone calls and talks to them about suicide care? Because we know that the best response is the one that we're going to plan ahead of time. And so I really encourage you to do that. And because one of the things we know is that if we don't ask people, we're going to not have ways that we can train people to respond. Go ahead. And thinking about what the role managers play, I've had so many middle managers call me and say, you know, I was in the break room and somebody made a suicidal statement, or somebody reported that somebody made a suicidal statement, or I know I'm not supposed to be on Facebook, but I saw this person posted something about suicide, you know, on a social media post. And so really thinking about what can you do and how do you train people to respond? And it's so important to talk about training managers, training everyone. How do I respond? What do I say? And giving people some language and then practicing at staff meetings. I actually came up with something when I used to train residents and trainees, because when they're sometimes caring for patients, they would get a little discombobulated and need something generic to be able to say to kind of get back on track. And so we talked about storage statements and coming up with 2 or 3 things that you could say to someone. Thank you for telling me you're thinking about suicide. Your life is very important to me, you know, and then being able to respond. And so thinking about what that looks like. Go ahead. So giving the managers a guide, there's actually tools out there that you can give managers. I one time had someone call me and they say, we have someone that works. She was a medical assistant and she was talking about suicide and we wanted to make sure we kept her safe. And I said, well, where is she now? And she said, well, we put her in the supply closet so that she couldn't leave and we would know where she was. I mean, you can't. And so what that really was is we hadn't trained our managers in how to respond and what to do, right? So really making sure that you're giving managers a guide, that it's part of your onboarding, that you're giving them some language and resources so that people know what to do. Go ahead. So one of the things, and we've talked about some of them, it is so prevalent that people feel that their employers are going to have access to their health records, particularly if they're self-insured, and that it's going to really hinder. For many of our people, our residents, our trainees, our front desk, people are living paycheck to paycheck. And so how much does it cost? People often assume, well, I can't call, right? And so we want to make sure that people know this is what our mental health benefit is. Here's what it could cost. And also that we give people resources. 988 is up and running now. It's national. That should be posted. Interestingly, more than 2/3 of the calls to the Lifeline get resolved on that call and don't need any follow-up intervention. It's evidence-based. We should put it around. Everybody should have it in their phone so that they know what to do and know what to call. And so really making sure that people have that information and that it's posted for everyone. Go ahead. So thinking about training, oftentimes we say, you know what, I saw this great presentation, with Verna Little and Dr. Barrett, and it really inspired me to go ahead and do something in my organization. So one of the things we want to try to think about is we're going to train everyone on suicide. And these one and done trainings don't work, because it's how are we really going to address keeping everyone safe across the organization? How are we really going to bake it in? How is a new employee going to know about how we care for people at risk for suicide and what to do if they're at risk for suicide or they know that someone else on the team might be? That we do very specific trainings. We should train our residents very different than we train our billing team. Because we want to give them specific responses. I was talking to a billing team recently and the manager didn't want them in the training. And then when I said, well, oftentimes, people fall through the cracks, and the billing team said, oh, we get suicidal statements all the time. Like, people make suicidal statements to us all the time when they say, oh, well, this is just another bill. I have so much financial pressure. I don't know what to do. I wish I was dead. Or this is the final straw in terms of owing all this money. And so really, not doing a training, a sort of a one size fits all. I have learned over time that it's really helpful to talk to residents sort of as a separate group, because we've sort of been talking about them, to train around suicide, caring for people, and then caring themselves. The other thing that we've learned around a suicide safer care organization is that oftentimes we bring people on, we train, we give like a 1-day HR orientation. Like, the best thing that happens is you get a good lunch, right? And then we train them in the electronic health record, maybe a day or two later. It's better to bring everything together. This is how we care for patients. This is how we document it. This is how we care for each other. Here's some ways to reach out for help, so that everyone gets it all at one time. So there's lots of resources out there about how to have a good training program. One of the things that I have heard in training clinicians how to care for patients is that they've said, I've learned actually questions to ask other people, questions to ask my team members, and even some ways to help care for myself. So it definitely runs across. Go ahead. So thinking about training as an organizational approach, because this is really around keeping everyone safe. So how are we reinforcing the training? So if we're going to train everyone now around resources and their mental health benefits, and we're going to give out some resources, how is that going to get reinforced? So maybe every couple of months when people turn on their computers, there's some information and 988, right? Or maybe there's a link to the Now Matters Now website, which is great for providers and for people who are struggling with suicidal thoughts. It's evidence-based, right? And then what exactly are we going to try to do? This infrastructure. So is it going to be built into onboarding? What is that going to look like? And how are we going to carry it forward? So when we think about suicide safer care system approaches, again, top to bottom, bottom to top, this is not something that you're going to leave here and say we have a project or a program. Projects or programs have beginning, middles, and ends. You have to really think about it. How are we going to address suicide risk across our entire organization? We're going to bake it into quality improvement, to safety, to our emergency preparedness, all of this, and that we're going to hold people accountable to make sure people get trained and the information gets disseminated, not in a punitive way, but in a way that we as an organization strive to make sure that everyone is safe and well. And to think about champions. So oftentimes there are two kinds of champions doing this work, volunteered and voluntold. So one of the things that I've learned is that it is better to wait for champions to rise, because oftentimes we voluntold someone that we perceive has a little extra time on their hands. Whereas if we do this work, you're going to hear people like Dr. Barrett say, you know what? when I was a resident, I lost a colleague to suicide, and I'm really invested in being a part of this work. So let them rise. Okay, and so go ahead. So creating a culture of wellness, and really making sure that we're engaging everyone, and really making sure that we're continuing to create this culture of wellness, and that we talk about suicide, and we talk about suicide openly. Go ahead. We want to make sure now that we're really talking about this at staff meetings, and that we're making sure that we have in our response plan time to address posts that we see in social media, as an example. Big problem. Or sometimes we find out about a death in social media first. Go ahead. So postvention, we talked quite a bit about this, really making sure we're planning now. There's lots of information on postvention. I'll put them in the chat while Dr. Barrett is talking, so that you can have some information to refer back to.
So thank you again, Dr. Little. You covered so much ground. It's amazing. And I love the holistic approach, because that is, of course, what we need, right? That is the only way that we're going to be able to get this work done. And then I feel like that, and thank you in advance for adding the information about postvention, because I think that people can misunderstand that the role for postvention, of course, is that we support the people who are affected. What we're also doing is preventing the next suicide, because it is something that can be contagious, right? So there's and that really underscores that we need really a cultural shift within our workplaces, and a cultural shift starts with each of us, right? So we talked before about how there can be these many barriers to our clinicians and really all healthcare workers seeking mental health care. And so I wanted to sort of bring us back to that before going to the next slide, where we can talk about how many of these barriers can be overcome. And you just heard a lot about them, and I can't overstate the importance of everything you just heard. And that also includes, of course, how we talk openly about care seeking. I will say that when I forget what I was presenting on, when someone had said to me, like, oh, do you have a therapist? And I'm like, yeah, I'm a doctor in a pandemic. Before we had vaccines, I spent 14 months on a COVID ward. Yeah, of course, right? And I've never met anybody who said, wow, I wish I started therapy earlier, right? So, oh no, I wish I started therapy later. Nobody says that. Everybody says, wow, this is great and this is important. Other things that we can do, of course, like you heard, is have an anonymous process to be able for people to receive care, is going to be something that also is, and to support each other in a way that we are not, that anonymous process, so that everybody doesn't know what's going on for you. I'm going to ask people to really consider having opt-out mental health care. And that's based off of an article that I had read, and then I adopted at my own institution. But in this case, it was, I'll put it into the chat when I'm done, but it's it was a residency program in Kentucky. And what they did was that they prospectively enrolled all of their new interns, so the people who had just brand new doctors in their training, and that they enrolled them all in mental health care appointments, one initial appointment, and they said you can opt out of it. And what they found was 91% kept the appointments. So that shows that the need is there. People will take advantage of it, and we can lower barriers so that it can be easy for them. And it doesn't have to be solely with our residents. We can decide as an organization that we want to do that. I'll say at my institution, when I decided to pilot this and did it with the help of a couple other colleagues, we did it through our employee assistance program. We connected them. We called it a wellness check-in in case people were afraid of receiving mental health care. What we did find was that we had scheduled 106 people, 79 kept the appointments, 10 circled back to say, can you reschedule me? I missed my appointment, who had missed it. And another 4 had decided to continue to receive mental health care. And overwhelmingly, when people informally were talking about it, then we had people come back to us to say, you did that for the interns, could you do it for our entire residency program? So we heard that from surgery, we heard it from family medicine, internal medicine, and also critical care, and I think dermatology. So really from a lot of different people. So again, that could be an option that people can do. And then also to contract with the mental health services providers who have flexible hours, because we're going to remember that, like that nurse that you just heard about, they're working. How are they going to get there? So we need somebody who has usual after hours access, and also maybe weekend access, things like that. And then also to the extent that we can, to work with if we are in a position, if people here, some of you are going to be HR leaders, that maybe we can waive the copay for employees receiving mental health care. I mean, that's a huge thing, because you know, I'm a doctor married to a doctor. I have a $20 for a copay, but for $20 for somebody else is a lot of money. So, so we should really look to see if that's something that we can do. So we'll go to the next slide, please, and come back to then this other big thing that we can do, which is that we can work on our credentialing applications, because that's something that all of us, our employers have it, and it is something that can be changed without needing a state mandate, without needing anything else. This is an article that that I co-authored that was in Modern Healthcare, and I had added it to the chat. But the idea that what we did was we tied together with some other national leaders, like what could be some best practices here after reviewing the literature, and we came up with a few. And but one of the things that came from it is that people really, they don't just need the information, they need the resources, and that gets to what Dr. Little was calling for. So we'll go to the next slide, please. And I'm going to ask you to take out your smartphone, because if you point your smartphone's camera toward this black and white box at the bottom, this will direct you to this website. And this is a resource to help you advocate for removing this removable barrier that is a question about mental health on your job application, so that people can actually, they will feel like there's one less barrier to them receiving care that we know is a real barrier. And when you get to this website, you can also find it through the WebEx chat, that that you'll see that these are downloadable resources. And so it literally is what you can see here. Like there's a PowerPoint slide, and we titled it, "Add this slide to any upcoming presentation on using tools to reduce stigma in medical applications." It is the slide you're looking at. So you can just you're asked to talk about billing. What you can do is, you know what, I'm going to ask us to do one more thing in addition to billing. You're asked to talk about maybe like a new policy or procedure. Just toss this one in there too. There also is just like, well, what are the common questions and how do you respond to them when you're asking that applications don't stigmatize mental health, and you're coming up with people asking you these common questions. It can be things like, a common one is, well, but we want to make sure that the patients get safe care. Well, we've got an answer for that, and it's actually the thing that you already heard about here, which is like, well, when this is studied, that it's not the mental health diagnosis that predicts how people provide care, right? Whether someone has a diagnosis, that's not about their ability to provide care. It's whether their impairment, which can come, they're impaired, that can come from so many other different sources. That's the thing we should be focusing on, right? There also is a whole presentation that if there's students on the call, or if you feel like you just want to look at this presentation, that if a student wants to present to other physicians or another audience on reducing barriers to mental health care for both students and for physicians, it has speaker's notes also too. Just use the whole thing. And then we have an email that you can, and there's more resources than you can see here, more than I could fit on this slide, but that you can, that there's a draft templated email that a student could send to their Dean of Student Affairs. There's another draft templated email that's nearly the same that anyone can send to their organization to request removing these questions. And you can just cut and paste it, add it to your email. A colleague of mine, he and I, who worked on some of these, I recommended him as a speaker at a national presentation. There were like 10,000 people at the meetings. And then a woman followed up and said, oh, actually, since that meeting, I just used all your resources and got this changed in my organization. So it really can be as easy as that. It often is harder than that, but that's why we have all these resources to try to support you. So with that, we're going to go to the next slide, please, so that you can know that, well, what are we recommending when we're in there instead? Is that if you have to ask some question that gets at safety, because, you know, we want the patients to receive safe care, but people receiving mental health care is not at odds with having safe care. In fact, it supports safe care. So instead, you can ask this question instead. And that's always easier when someone says to you, well, what are we going to do instead? What are we going to do? Have everybody be able to provide care? No, what we're going to do is we're going to ask something else. And what we can ask is this question instead. Do you currently have any condition? So it's currently is important, right? That adversely affects your ability to practice medicine in a safe, competent, ethical, and professional manner. And you can change this question to practicing nursing, to practicing respiratory therapy, to practicing whatever it is for your clinicians. You can do this instead. This is one that has been widely adopted. Or you can choose not to ask any questions like this at all. That is what the state of New Mexico recently decided. So we'll go to the next slide, please. And when you're going to be making this case, I am going to really ask that you can do this too, which is that you provide a statement of support in every application, that we also provide a statement of support that builds upon every single thing that you heard from Dr. Little about the need. This is part of a culture, is taking care of each other. So this could be one version of it, which is, it is common for clinicians to feel overwhelmed from time to time and to seek help when appropriate. We want to normalize this, right? So we emphasize the importance of well-being and appropriate treatment and support for all conditions. That's it. You can add that statement of support anywhere. Anywhere that there is an application where someone might feel like they're afraid to seek mental health care because they're afraid to have to answer a question on an application. What you could do is you could also follow this with what are the resources your organization has. So say, for example, the state of New Mexico recently adopted a statement that's a little bit different than this, but the spirit of it is the same. And they have a specific line that says the New Mexico Health Professional Wellness Program is free and available to you, and that they have the information there. So that is something all of us can do. You can add your employee assistance program. You can add the 988 line. You can do whatever is the program, the services that you have. So we'll go to the next slide, please. I hope that in the intervening slides that I had convinced you that this resource, this is something that you can do, that you can encourage your organization to ask that, to either remove all questions, certainly remove all questions about mental health, but then also instead to ask about safety, competency, professionalism, ethics, and that you're, and also to add a statement of support for receiving mental health care. And that again, how you can do so is that you can feel supported in knowing that there are a lot of resources that are here available for you on this website, accessible via your QR code. This is a website that is through the Institute for Healthcare Improvement. And I don't get it, although I'm a faculty for them. I don't get a toaster if you access this. I just put this up here because I really believe in it and because people have said that it has really helped them. So I'll stop there, and I think
there's a question in the chat you might want to, I know you were speaking and may not have had a chance to see it. How about adding a question? How about adding questions that ask how a person is managing their mental health diagnosis if they don't want to remove the initial question, the way we normalize the idea that a mental health diagnosis is similar to any other medical diagnosis that needs to be managed?
That's such a great question. I would actually recommend against that. And I would recommend instead one of the other approaches, the approach that you saw mentioned. And the reason is because people will be afraid to answer this question. It will have implications, and it could have implications for the Americans with Disabilities Act, and nobody wants to set up their employer for possible complaint litigation, having to manage that downstream. But instead, what I would say is how we can normalize that a mental health a diagnosis is similar to other medical diagnoses or conditions that need to be managed. We can just have that statement. And so instead, we don't imply it. We just flat out say that mental health diagnoses are similar to other medical diagnoses or conditions that need to be managed, and we support you receiving the care that you need. I wouldn't ask about how they are managing it, because how they're managing it, it will, we do run into HR problems there. We can run into that. They will be afraid. They probably won't answer honestly, many of them, most of them. And it will likely make people afraid to respond. And because people weaponize, it doesn't happen often, but one of that story that I told you about my colleague who I sat across from, and I said, "Are you okay? Are you okay?" And the next day he killed himself. He was actually somebody who in that organization, a previous clinical director had actually held over his head that he had had depression, and said that he would tell other people and out him. So most people will not do that. Most people have good intent, but we don't want ever to set anyone up to have their diagnosis that especially is not impairing. They're able to take care of patients that could be weaponized by anybody with ill intent.
And there's a follow-up in the chat about asking a question.
Yeah, I don't recommend the actively managing question either. It will deter people. It will absolutely deter people from seeking care, and it will not get to what we need to know, which is, can they provide good care of the patients? So that's why I don't recommend it. And it likely will run afoul of the Americans with Disabilities Act. But that's a good question. I'm glad that you're, and I'm glad that you're thinking really critically about this. Instead, what I would recommend is instead just asking the proposed question. Maybe what I'll do is I'll cut and paste that language into the chat in case people didn't get a chance to grab that QR code. And I think that there's probably a question in there that is probably best for Dr. Little. Oh, no, it's a statement that you had said.
Yep,
and
I
when
sent it. Yep.
Okay.
Just to remember to ask, I was struck by your conversation and to say, sometimes when people are not okay, they think about suicide, and I'm just concerned, that you're asking very directly.
Yeah, I wish I had. Yeah. And he may not have told me the truth, but I would have,
Yeah.
I lived with myself better. And for people who are looking at, they're able to access the chat, that I just cut and paste the language that we can ask instead. And also a version of a statement of support that we can ask, that we can add to any application anywhere.
Thank you. You're such a wealth of information and knowledge.
You are.
Thank you both for the excellent. We're now at the top of the hour, so I just so if you have any questions that we weren't able to get to in today's Q&A, or just that you were thinking of, please don't hesitate to reach out to me. You can reach out to me at rbrown@clinicians.org, and I'll try to address your questions. Also, please don't hesitate to reach out to us for more information via our Suicide Safer Care page, which you can find at the link in the chat. Also, as we conclude for today, I just wanted to take a quick moment to remind you to please complete our evaluation. It's tremendously helpful to help us improve the quality of our trainings. And with that, I just wanted to thank Dr. Barrett and Dr. Little so much again for today's presentation. And with that, I hope everyone has a wonderful day.
Thank you, everyone. It was a privilege.
Thank you.